Okay, I guess we will start. Yep. Good evening, everyone. Respected Dr. Pavana ma'am, members of the Safe Dental Updates, and dear doctors. Welcome back to our 48th episode of Learn from Our Master series organized by Safe Dental Updates. And it's a beautiful journey so far. And I thank all the doctors who are attending our webinars so far and also visiting our platform like our Instagram and our YouTube channel. And we are very humbled to see your positive feedbacks. So, for those who are attending our series for the first time today, I would like to do a little bit of introduction about ourselves. We are Safe Dental Updates, a dental platform in which we believe quality education always ensure predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the observation that the dentistry is complex and requires ongoing learning experience. So we conduct various webinars and workshops to enhance the skills of dental professional and guide your dental journey. So without further ado, let us start our series in which our topic of discussion is different methods of achieving the glide path and its significance given by Dr. Pavana. To speak a few words about Dr. Pavana, Dr. Pavana Kamath completed her MTS in Conservative Dentistry and Endodontics from Manipal College of Dental Science, and she's been practicing microendodontics for past 22 years. She's a chief faculty in Fellowship of Microdentistry in IDA Prabhadevi and director in Upskill Dental Academy, Mumbai. She's a key speaker in Style Italiano Endodontics, IACDE National Conference and International Conference, and FAMDEN Mumbai. She has published innumerable articles in index journals and conducted various hands-on workshops in endodontics and dental operating microscope in the academy as well as in IT. So without wasting more time, I would like to invite Dr. Pavana ma'am for today's discussion. Ma'am, please.
Thank you, Dr. Shanu. First of all, I would like to thank Safe Dental Updates for coming up with this wonderful platform providing quality education as well as a platform for learning and sharing. Secondly, I would like to appreciate all the members of Safe Dental Updates who are present today on a Sunday evening attending a webinar. I truly appreciate your passion for dentistry. Without further ado, I shall begin with the webinar. So the topic today is different methods of achieving the glide path and its significance. When we speak about glide path, let us take a different look or perspective for glide path. Just a moment. Yeah, can you see my slides?
Yes, ma'am.
Yeah. So to glide, what exactly is glide? Glide means you move in a smooth and effortless way. And a path is a long strip of ground which people walk along to get from one place to another. If you were to put the two together, the glide path is basically to smoothly glide in an effortless way from one point to another. And that is glide path. Very similarly, the endodontic glide path is a smooth radicular tunnel from the canal orifice to the physiological terminus, that is your foraminal constriction. And every time a dentist initiates root canal therapy, he establishes a reproducible glide path every single time. And the most commonly used instrument for establishing a glide path is a simple stainless steel number 10 endodontic file. Let us understand the significance of glide path. Whenever we treat an endodontic infection, a root canal therapy success depends upon the biological insights of the dentist, which he combines with his technical knowledge and skill. What I mean to say is biological insight means that endodontic disease is a biofilm-mediated infection, and the primary aim in management of endodontic disease is the elimination of the bacterial biofilm from the root canal system. The most common endodontic infection is caused by surface-associated growth of microorganisms, and it is important to apply the biofilm concept to endodontic microbiology to understand the pathogenic potential of the root canal microbiota. You have to encounter endodontic biofilms as intracanal biofilms, extraradicular biofilms, periapical biofilms, and biomaterial-centered infections. What I mean to say is you will find these biofilms within the root canal dentine. Extraradicular biofilms are located at the apex periapically. Periapical biofilms are located in the periradicular lesions, and biomaterial-centered infection, that is, biofilms which are located on the surface of gutta percha, which you will be using for obturation. So basically, the operator has to eliminate the surface adherent biofilm bacteria, which is a major challenge, and different antimicrobials ranging from antimicrobial agents to advanced antimicrobial methods such as lasers, photoactivated disinfection, and nanoparticles are employed in the management of infected root canal systems. Simply put, at our clinic, chemomechanical debridement plays a key role in treating these endodontic infections. So basically, root canal treatment is a procedure which is used to either prevent apical periodontitis in its initial stages, or once established, we attempt to treat or resolve it. So basically, we have two ends of the biologic disease spectrum, which also defines the two ends of outcome spectrum. What I mean to say is that when you're treating a root canal where there is minimal or absence of apical periodontitis, there is actually absence of periapical bacterial colonization. So here, you might actually find a little bit of vital pulp in the apical thirds of the root canal also. So here, when you're treating a root canal of this kind, the prime requirement in management is simply asepsis. Asepsis in instrumentation, in irrigation, and obturation. And doesn't require some extraordinary skills, and the result and the outcome or success rate is above 90%. Whereas if you are treating a root canal with a large periapical lesion, then you are aiming at removal of an established biofilm in the apical third anatomy. A larger lesion means greater infection diversity of microbiota, which also means greater is the challenge for eradication. Now, when we look at the technical perspective, now technical perspective is something which all of us dentists are familiar with. Whenever we think of root canal, we are thinking about the technical aspects. That is, okay, we have a root canal to perform, so we have to gain access, we have to locate the root canal orifices, we have to negotiate them to the apical terminus, we have to enlarge the canals, disinfect and obturate them. So basically, if we were to put the biological insights and the technical know-how together, we can conclude that obtaining a reproducible glide path and maintaining apical patency is the single most important factor to achieve a predictable root canal treatment. Now let us look at the root canal system and its complexity. The preparation of root canal systems is one of the most difficult tasks in endodontic treatment. And this is due to the complex anatomy of the root canal with irregular cross sections, which are non-circular, multiplanar curves, bifurcations, trifurcations, fins, and cul-de-sacs. And that is why the significance in establishing the glide path. The ability to negotiate the main canal system to their termini with the root canal instrument has been identified as a single most important treatment factor contributing to a favorable periapical healing outcome of teeth with apical periodontitis. Now, what it means is that despite the complexity of the root canal system, if the operator is able to negotiate the main canal system, it provides you access to the complicated system good enough to achieve a favorable periapical healing. That is the significance of a reproducible glide path, which is the only guiding strategy to the use of rotary night-eye instruments, which has become the norm in preparing the root canal systems mechanically. Also, a reproducible glide path of a sufficient size reduces the torsional stress in NITI rotary instruments, and it also increases the lifespan of the rotary instruments by almost 6 times. So without endodontic glide path, it is not possible to achieve the rationale of endodontics, which is any endodontically diseased tooth can be predictably saved if the root canal system can be non-surgically or surgically sealed and the tooth is periodontally sound or can be made so and the tooth is restorable. The glide path is necessary for quality control and sustainable excellent endodontic obturation is not possible without it. And we very well know that lack of glide path establishment may result in ledge formation, blockage of root canals, transportation, zip formation, and perforations, and even instrument separation. So now let us understand how do we negotiate canal and establish the glide path. Whenever we begin root canal treatment, after access opening, even before access opening, there are some basic principles according to Mons in 2004, where he described these basic principles are essentials before initiating the root canal treatment. That is, a comprehensive assessment of the root canal system, determine the number of canals, the location of canals, the length of canals, the curvatures at different levels, and presence of calcifications and presence of anomalous anatomy and difficulties in access. And this should be done at the very outset. There are various instruments available in the market for preparation of glide path, both manual as well as mechanical. The choice of instrument is purely personal. It depends upon the operator convenience, comfort, as well as the clinical condition which you are going to deal with in that particular tooth. So what are the steps in establishing glide path? These are the basic steps to establishing glide path. First and foremost, locate the root canal orifices. Now, the factors to be considered while choosing the glide path file. Dr. John West surveyed the American Association of Endodontists and reported his findings in the AAE annual scientific meeting in 2010. And the above were the questions which he had presented to them. And we will not only we during the session, in fact, every dentist considers these factors every single time he establishes a glide path in any case which he initiates for root canal therapy. And they are, what is the size of hand file that you would prefer for glide path? Would you use straight manual files or would you curve them? Would you use the file to go to length immediately or would you prefer an early coronal enlargement? When making the glide path, what is your preferred irrigating solution? How would you determine your glide path length? And when making the glide path, what hand file motions do you use? Would you prefer a simple watch wind motion, a push-pull motion with a small vertical element, or any other? So these are the very same questions which I shall be addressing, and these are the same questions that come to our mind every single time. First of all, coronal pre-flaring. Whenever we place an instrument in the root canal orifice and negotiate it to apical terminus, there is some amount of restrictive dentine initially, and this interferes with the tactile sensation of the instrument, especially the tactile sense which we require in the middle and in the apical thirds. So this can be dealt with in a very simple manner, and that is by coronal pre-flaring. Coronal pre-flaring is nothing but eliminating the restrictive cervical dentine, which is a small triangular cervical dentine, which is generally present at the beginning of the root canal orifice. And this can be easily removed with an ultrasonic instrument, or you can use an orifice opener to establish the coronal pre-flare. As you can see in the image, once the coronal pre-flaring is established, there is freedom in the coronal thirds. Automatically, the file's tactile sense improves in the middle and in the apical third, and the file is able to scout the middle and the apical thirds of the canal. So you perform the coronal pre-flaring with a rotary file, and then you move on to negotiating the canal. And here I'm using a number 10 stainless steel K file. I take a brand new number 10 stainless steel K file and I pre-curve it using cotton pliers. So what is pre-curving a stainless steel file and how does it help? When you pre-curve a stainless steel file, you create a small curvature in the apical third of your file and you insert it into the root canal. This curvature generally achieves an accurate match with the canal system, and that helps you in negotiating the file into the root canal up to the apical terminus. It also helps in reducing the restoring forces which are present in your stainless steel file. Now, these restoring forces could be harmful because it is a tendency of the file to go back to its original form because it is a rigid file. And this could change the anatomy of the root canal system, which can be controlled by pre-curving. Once you have reached the apical terminus, you have to make a controlled amplitude vertical stroke filing to maintain the glide path, to smoothen the glide path, to make it reproducible. And that is the significance of pre-curving. Scouting. The file which is used to establish the glide path is the one which is also helping us to scout the root canal system. What do I mean by scouting is exploring the root canal system anatomy to understand how best we can prepare it mechanically and debride it efficiently with disinfection, along with disinfection. So scouter files can provide information regarding the root canal system anatomy. 5 commonly encountered anatomical forms, which include canals that merge, curve, recurve, dilacerate, or divide, and you're familiar with these terminologies. The Scouter files provide critical information regarding the anatomy and give an important feedback regarding the canals, degree of curvature, recurvature, and even if there is a dilaceration. One of the most important benefits of using a Scout file is that if there are some anatomical configurations which could preclude the safe use of night eye rotary files, we would come to know at the very initial stages of establishing the reproducible glide path, and we can avoid any kind of iatrogenic errors. A small scouting file, when steered clear of the coronal restrictions, can help in a great way in determining the diameter apically as well as the apical third cross-sectional anatomy, which is of great benefit in root canal preparation. And once we have scouted the root canal system, we have to just create a smooth glide path to the physiologic terminus, which is as simple as or resembles a child riding down a slide in the park, randomly going down with the flow of the slide. That is exactly what we have to do. Using minimal apical pressure on the file, we have to slip, slide, glide, and follow the canal to the apical terminus. And that is how a glide path is established. Once you reach the apical terminus, a breakthrough to the apical one-third finishing procedure is established with the canal patency, and this is performed by gently pushing a small, highly flexible 10K file to the radiographic terminus. To ensure patency, the file tip is intentionally inserted 1 millimeter through the foramen to discourage the accumulation of debris. And when you do so, you do not perform any watch winding motion. It is just intentionally inserted 1 millimeter through the foramen. Working a small flexible file to the radiographic terminus will encourage the elimination of all pulp and related irritants and dentinal mud. Keeping the canal terminus patent discourages blocks, ledges, and perforations. What is meant by incremental instrumentation? This is something which we all have encountered. When we are negotiating the glide path is easily established in the coronal third and the middle third, but when we move towards the apical third, the diameter is very narrow and the file size is sometimes too big for this. And we have a natural tendency to apply more apical pressure at this point of time, which could be detrimental to the apical third anatomy. In order to avoid this, we have to follow the method of incremental instrumentation. That is, we begin negotiating the apical third with the smallest number 6 stainless steel file and then come up to number 8 stainless steel file and then number 10K hand file. So this allows instruments to be placed in the apical third without forcing, and the working length is naturally gained without the need to use forceful reaming action. And that could be very safe for the apical foraminal area. Irrigation. Irrigation during the time of establishing the glide path is essential. Copious irrigation with sodium hypochlorite acts as a very suitable aid in establishing a reproducible glide path. The frequency of irrigation is dictated by the amount of work that a particular instrument performs. It is axiomatic to always irrigate, recapitulate, and re-irrigate just before the canal becomes blocked. Now, why do I mention that? So every time you establish the glide path and you negotiate the file in the canal, you're engaging the dentine and you are removing dentine, creating debris. This debris tends to accumulate in the apical third, which is why the canal could get blocked, and frequent irrigation with sodium hypochlorite augurs the debris to the coronal orifice. Now, this is an image of a maxillary premolar cross section where two files have been placed in the buccal and the palatal canal in the image to the left and only in the buccal canal in the image to the right. Now, this clearly explains all the steps of establishing the glide path. First of all, the axis is adequate to achieve straight line access to the apical third. The coronal pre-flaring has ensured that. One more thing that we can see now, if we observe closely, the apical third displays an anatomy where there is a bifurcation or a trifurcation. And when the files were pre-curved in a certain way, their incidence has been towards the canal, which is located towards the left. And when the file was pre-curved differently, it has shown tendency to negotiate the canal, which is more towards the right. So that is the role and benefit of pre-curving an endodontic file while negotiating the canal to the apical terminus. To the right, we can see a few images. Now, these images basically describe the difficulties which we encounter while establishing glide path. The first and the most common being a block in the apical third of the root canal. Now, this block is not necessarily a calcification. It is actually formed due to dentinal mud. It could also be some amount of vital pulp tissue, which could be blocking that area. So the operator has to withdraw the file, go back with copious irrigation with sodium hypochlorite to dislodge the dentinal debris and also to dissolve the organic matter and then re-enter the root canal to negotiate the apical third. And this requires patient filing, withdrawal, irrigation, filing, withdrawal, irrigation until the glide path is established. Now, the image number 2 signifies the importance of pre-curving the file to match the anatomy of the canal. If the file is pre-curved, slightly different from the anatomy of the canal, the angle of incidence of the file inside the canal changes. So it will not be able to negotiate the last part of the canal. So if such a situation happens wherein your radiographic measurement from the diagnostic X-ray does not match the length of glide path which you have achieved, withdraw the file and irrigate, pre-curve in a different way and reinsert and continue the process till you finally get the pre-curve which matches the anatomy of the canal. Suppose you use an instrument which is larger than the apical diameter of the root canal system. It will feel like a block while it is not actually a block. And in such cases, you have to withdraw that file, irrigate with sodium hypochlorite and go back with a smaller file. And suppose you're negotiating the root canal and the shaft of the file is too large to allow the entire length of the file to negotiate the root canal system, one has to go back and come back with a smaller sized file. And in this way, we can manage most of the problems which are encountered while establishing the glide path. It is not necessary that you will encounter one problem at a time. Sometimes you could have all 4 situations put together in one root canal, and sometimes you could have a combination of 2, 3, etc. So this is a diagram which clearly explains the importance of physiologic apex, anatomic apex, and radiographic apex. Now, I have placed a file in an extracted tooth inside the root canal and radiographed it. The file has clearly extruded 1.5 millimeters beyond the physiologic apex. First of all, the physiologic apex is not located at the tip of the root. It is located slightly laterally. So it has gone beyond. The anatomic apex is somewhere else, that is the tip of the root, and the same tooth was radiographed, and you can see that my root canal file has reached exactly the radiographic terminus. And that is the reason once you have established the glide path, it is important to record the working length with an electronic apex locator and then proceed with chemomechanical debridement of the root canal space and obturation. Now, according to Dr. John West, by following to the radiographic terminus, the clinician guarantees foraminal patency, which is a prerequisite for a successful glide path. This is important. It is about the glide path and not working length. We have just discussed this. So basically, the process of establishing a reproducible glide path is nothing but negotiating the root canal, following the root canal to the apical terminus, using small vertical amplitude strokes to smoothen the root canal and enlarge it to number 10K file super loose, using the envelope of motions to establish or negotiate difficult anatomies, maybe dilacerations, maybe trifurcations, bifurcations, and creating a healthy balance. What it means is that the glide path, which is reproducible, has to be prepared to a size which is one size larger than the first instrument, rotary instrument, which is inserted for preparing the root canal. The armamentarium, as we all know, either hand files or rotary files can be used for establishing the root canal. Glide path preparation techniques can be both manual as well as mechanical. Now, the most commonly used instrument for establishing the glide path is the K files. They provide adequate tactile sensation and gentleness as well as rigidity to negotiate a root canal at the very outset. So whenever a small K file, number 10, generally is inserted into the root canal, when we withdraw it, you can actually see the impression of the canal, whether it has a single curve, whether it has multiple curves, etc. The stiffness of the stainless steel hand file aids in pathfinding and negotiating blockages and calcifications. Above all, it is economical to use a K file and it does not require a dedicated handpiece. And stainless steel instruments provide the most sensitive, controllable scouting and negotiation to produce a reproducible glide path. However, they do have their disadvantages. When you're negotiating say a relatively sclerotic or calcified root canal or a canal which has an extreme curvature, there is definitely operator fatigue and hand fatigue. There is risk of introducing aberrations when you progress to larger hand files. It is definitely time consuming and requires a lot of patience. And there is a greater change in the original canal anatomy when you use a hand file. One other method to enhance the hand files is by using the M4 safety handpiece, which is a contra-angle handpiece. This fits into both E-type slow-speed handpiece as well as into the TF adaptive motor. Now, the benefit of this handpiece is that it can plug in both number 6, number 8, as well as number 10K files, and it mimics the watch winding motion which we use to negotiate the root canals. So M4 safety handpiece gives the added benefit that we can establish a reproducible glide path much faster than when you do the hand instrumentation. The best way to use this handpiece would be to use a manual method to reach the apical terminus and then engage the M4 safety handpiece on the head of the file and activate it to prepare your glide path to super loose number 10K file. Rotary glide path files. There are numerous rotary glide path file systems available in the market, and they're 2 to 3 times more flexible than your stainless steel files. They have more torsional resistance. They are better at maintaining the original canal anatomy, and there is lesser chances of apical extrusion. And they use the same reciprocal motion. Now, the disadvantages when you use a rotary file is there a tendency to screw up inside the canal and over-instrumentation of apical foramen and increase in torsional stress when the screw-in occurs. So what is this? Basically, when you're using a rotary file, it is performing the same work as a manual file where it is engaging the dentine and it is removing the dentine and improving the size of the root canal to a number 10 K file. So when you do this, in case of a rotary file, it is applying two forces. One is the torque, which is in action, that is a horizontal force. And the other one is because you're applying the pecking motion, there is a certain amount of force which is applied when you withdraw the file from the apical third. And both these forces can produce a lot of torsional stress. And when you engage the dentine, the screwing in occurs, and this can be avoided by using gentle vertical strokes and pecking motion. So mechanical glide path preparation also follows a reciprocating motion, and it has high cutting efficiency, reduced extrusion of dentinal filings, and better centricity. The canal diameter after glide path should at least be one size larger than the tip diameter of the first rotary file to be used, and the minimum dimension of a reproducible glide path should be a number 10K file. And you can use balance force motion of hand files to establish the glide path if watch winding is not enough. The choice of instrument for establishing the glide path depends upon the diagnosis, the canal morphology, and primarily on knowledge, experience, and technical capabilities of the operator. Beruti et al. And Kwok et al. Reported that glide path preparation using rotary instruments is less sensitive to clinician expertise. So that kind of takes care of many factors, and it becomes faster and also maintains the original anatomy. So achieving predictable success in root canal therapy is possible with a reproducible glide path, and scientific literature as well as clinical experience shows that successful outcomes are more likely with minimal iatrogenic errors when instrumentation follows a reproducible glide path. Thank you everyone for your attention.
Thank you, ma'am. So we'll have a question answer session for
Sure.
you, and I would request the audience to post your questions in the comment section relevant to the topic only. Okay, so there's one question. Which irrigant solution is good during glide path preparation?
Basically, as I have already mentioned in the presentation also, sodium hypochlorite would be the best irrigant to use during glide path preparation. So what do you need when you establish glide path? You need a lubricant. So irrigants have different actions. They function as a lubricant, they act as a disinfectant, they help as a chelating agent. So when you use sodium hypochlorite, you're achieving the lubricating action, and it dissolves the organic material, and it is also simultaneously disinfecting your root canal because of its antimicrobial effect. No doubt, EDTA is an excellent chelating agent, but when it is used in large quantities, it could facilitate iatrogenic errors, especially in the very initial stages when there are many dentinal restrictions. It is safer to use sodium hypochlorite. Secondly, yeah, that's about it.
So another question is, how can we achieve glide path in severely curved canals?
Yes, I was just speaking about it. I was highlighting the pre-curving of files. In fact, I showed a slide also where there was pre-curving of files, and it has negotiated the apical third. Basically, when you pre-curve a file, you are trying to match the anatomy of the root canal. So we generally pre-curve the files to a gradual curvature when we are establishing a glide path in a normal canal which does not have excessive curvature. But in severe curvatures, you have to achieve the pre-curving to slightly more acute levels in the apical third of your file. That is, you give a higher curve or a more acute curve so that it matches the anatomy of the severe curvature. And it requires a lot of patience because severely curved canals require a lot of patience in handling. It could lead easily to all the iatrogenic errors that I mentioned, as well as instrument separation. It requires copious irrigation, and one has to concentrate on coronal pre-flaring, because when you work on the coronal zone and release the file from all the restrictions, it becomes easier for the pre-curved file to move smoothly into the curvature.
Okay, ma'am. So there's another question. What if we try to achieve a patency? Is there a chance for infected debris to go beyond the apex?
Yeah, so basically, a lot depends upon disinfection. So patency is basically to dislodge the debris which has accumulated in the apical third. It is very difficult to disinfect the apical third. It's not easy. And even after using ultrasonics also, it is difficult to pass the energy, the ultrasonic energy, to the very end of the apical third. And therefore, it is very important to recapitulate and establish apical patency repeatedly during your chemomechanical preparation. Apical patency is just inserting a file 1 millimeter beyond the constriction without any watch winding motion or any kind of action. So you're not actually, and that too with a small file, like a number 10K file. So you're not actually pushing the debris, you're just breaking the stagnant debris. And with the kind of disinfection that you're doing subsequently, there is very little chance for any kind of what do you call any kind of problem to arise.
Okay, ma'am. So, ma'am, what is your thoughts on the definders and the C pilot files? Will that help improve the glide path preparation?
C pilot files and definders are more rigid. So they give you, I mean, they're more rigid. So whenever you have like a sclerotic or a calcified canal, then you need you need certain amount of rigidity which facilitates better negotiation. So I would probably choose them then.
Okay.
But in most of the cases, I would stick to a K file.
Okay, I'm just trying to select some questions which is actually, so I would request the audience again, please only pose the question which is relevant to the topic only, not related to endodontics, just related to the topic only. Is it possible to do a glide path preparation? Sorry, okay. Is it possible to do a rotary glide path preparation at the beginning itself without manual?
I have never attempted it. I always start with a hand file. I always go to the apical terminus with a hand file, establish a reproducible glide path, and then enlarge it further with the rotary glide path files.
Can you share thoughts on using reamers? Does that also helps in glide path preparation?
Reamers also will help, but reamers do not cut like files. So it would just take longer.
So we'll just try to answer just few more questions only, just 2 or 3 questions only, and then we'll try to wind up this question, wind up the session. So what comes first? Is it the working length determination or the glide path?
It's quite natural. It's the glide path. That's what I was mentioning, that when you establish the glide path, you reach the apical terminus and establish the canal patency first. And once you've established the canal patency, I told you that we have three different terminologies. We have the radiographic apex, we have the physiologic apex, and the anatomic apex. And what we need for working length is we need the physiologic apex. So once you've established the glide path, then you switch over to an electronic apex locator and establish the working length before beginning the chemomechanical debridement of your root canal space.
Okay, I guess we will wind up this session, ma'am. If
Sure.
any other questions are there, we'll try to rectify it in any platform. Like ma'am has an Instagram platform as well, where it initially had contacted.
Sure.
So definitely, thank you so much, ma'am, for sharing
My
your
pleasure.
knowledge and expertise when it comes towards achieving a glide path And surely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. And thanks to all the doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with confident, positive manner. And once again, thank you so much, ma'am.
Thank you. Thank you.
Okay, it was a wonderful and informative discussion. We really appreciate your valuable time given for us for this series episode. Okay, so to know more about our upcoming webinars and workshop, please do check out our Facebook and Instagram pages. And also, if anybody has missed out any previous webinar, you can do check out our YouTube channel, and I would request you to subscribe as well. So thank you all, and have a great night.